can be a simple periodontal procedure. Because aesthetic problems can occur. What are they? Recession, discoloration of the gingival after treatment, and what else? Maybe if you look at the tooth from an incisal point of view, you see the facial contour, it collapses in. All three factors tend to go hand in hand with each other. If there's one problem, a lot of times it leads to another problem. So, to try to control or maintain aesthetics, what is the key methodology then? Well, in my humble opinion, to create so-called predictability. There's a little checklist I want you to take a look at on the left side of the screen, okay? And I will use this patient to basically walk you through, patient flying from Minnesota to Los Angeles to see me, failing front tooth with an infection, high smile line. So how do we create predictability? Especially when we place implant, and mind you, whatever I'm about to share with you today is basically linked up to any type of treatment, not just implant, can be on veneer, can be on simple as periodontal surgery. Okay, so what's the thinking process? Well, the first thing is to talk about is thickness. What do I mean by thickness? Every time when you use the term thickness, this is a big term in periodontology, by the way. Thickness, what are you thinking about? You say, oh, thickness. Phenotype, I know phenotype. Oh, that 2017 position paper by Cortellini. Oh, suddenly they describe a third type of phenotype. Now, besides thick and thin, thick and flat and thin and scalp, that's the third type. But my dear friend Cortellini, he's a dear friend of mine, he made a mistake. He didn't realize he actually missed one other phenotype. Because we're doing a new research to find out there's a fourth type of phenotype that was missed at that 2017 Journal Clinical Periodontology paper there. But the point is this, whenever we talk about thickness, what the heck does that mean? Now, let me tell you, what is confusing is, in 2025 today, thickness can be defined in a few ways. I want you to look at the diagram on the right-hand side there. You see that? The square box, what I highlight specifically is the area that if you talk about phenotype, that's a key area to look for you as a clinician when you look at phenotype from a periodontal standpoint. What does that mean? That means from the free gingival margin, you see that, and to roughly where the mucogingival junction is. Mind you, anytime when the soft tissue that is able to the mucogingival junction, the thickness is not as big critical anymore. The critical area is really, maybe we should use the term where the attached tissue is. If there's sometimes it's not attached to. But free gingival margin to mucogingival junction. Now, what you look for, when we talk about phenotype in 2025, we need to look at two things. What is it? The first thing is what you call vertical tissue thickness. Vertical. What do I mean by vertical? Where do you define that? Vertical tissue thickness starts from free gingival margin to, depends on what's underneath there. It can be a tooth, it can be an implant. If it's a tooth, the definition height of the phenotype is from free gingival margin to the underlying facial bone. Got it? However, if you substitute that with an implant, the phenotype vertically is from it's not the free gingival margin anymore. Once you put an implant in there, that is not gingival, we call that mucosal, okay? So, the free mucosal margin to the underlying implant platform is the vertical soft tissue height for the implant. Understand that? All right. So, but then we also need to understand tissue thickness in periodontology now, also defined in a horizontal manner. Got it? Horizontal manner can be in two areas. One is the area between the soft tissue and the bone. You see that? And then if you go a little bit more apically, it's between the soft tissue and, the first area is soft tissue and the tooth and the soft tissue and the bone. All right? So that's a horizontal phenotype. So in general, I want you to make sure you understand, every time when we define tissue thickness, we must think a little bit more. There's vertical and horizontal tissue components. Now, what should we know? First of all, let's talk about horizontal. What do I mean by horizontal? All right? How do we define? Because that's when people talk about thick and thin, right? What is thick and what is thin then? Well, classically, when you look at the literature, as the most practical way is take a periodontal bone and probe the sulcus And if you can see the vein outline of the probe shining through, what does that tell us? A little bit on the thinner side. A little bit on the thinner side. But in reality, what is the average facial gingival thickness? When we look at the periodontal literature, if I were to summarize all the periodontal literature that look at tissue thickness, and most of these articles use it to look at root coverage procedures, right? Like the Italian team, they measure the tissue thickness to see how much root coverage you can get. Is there any relationship? But in general, when you look at any periodontal study that measure facial gingival thickness of TP and aesthetic zone, if I summarize them, they come up to, in general, most of the time, between 95% of the time fit into these two numbers here, 0.7 to 1.5 millimeters. What I'm trying to tell you is this: most of your patients, the facial gingival thickness that you treat are not really thick. 0.7 to 1.5. Now, if you look at it, then if you look at this range of 0.7, 1.5, not very wide, but what is considered thick, what is considered thin then? Well, this group of researchers took the liberty and just draw a line right down and say, okay, so in general it's quite accepted. Anything less than 1 is thin, anything greater than 1 is on the thicker side. Got it? So, but what is the big deal? The big deal is this, okay? As a clinician, this article published in 2010, what you want to learn from it is this. I'm not here to bother you with all the research and stuff like that. Very simple. This article just asks a very simple question. You as a clinician, what is the best way to evaluate whether my patient is thick or thin? Why? Because people believe that if thin tissue, suddenly you gotta be very careful as a surgeon. Ooh, I gotta be a plastic surgeon now. Ooh, I gotta be very careful as a restorative dentist because I cannot be too aggressive to the soft tissue. Because by doing so, I'm going to have recession. So what's the best way? This study, very simple. They compare 3 ways. Clinically, visualization. That means I look at the gum, is it thick or thin? Then I use the probe that I just talked to you about. Then, upon extraction of this feeding tube, they use a tension-free caliper to do a direct measurement on the free gingival margin thickness, which is around 2 millimeters apical to the patient's free gingival margin. Got it? So, obviously, the most objective way is to measure. But compared to visualization and probe, which one is best? Let me give you a summary, so you don't need to be bothered with all the stupid numbers. Very simple. In this study, it shows that on 48 sample size, okay, if you look at it, visualization is the least effective way to evaluate phenotype. That means thickness of gingiva. And when they compare the probe and the direct measurement method, the probe is almost as effective than the probe and the direct measurement. So therefore, very simple. You go home tomorrow, you want to know, is my patient's gingiva, or you can go back and ask your wife, take a probe to your wife and say, hey, let me check. Can I see it? If you see the outline shine through, you tell your wife, you are thin, and she's going to be so happy. I'm thin, yeah. Okay? But if you don't see a probe, never say, you are thick, don't go there, okay? All right, so now, the thing is this, so this study. So the point is that visualization is not reliable, probing is almost as effective as direct measurements. So now, what happens if you go do a tissue grafting then? If you go do tissue grafting, a lot of people say, if thin tissue, let's do a tissue graft. But is tissue graft always needed? This article is very interesting from University of Southern California, maxillofacial surgery team. Barkley is from Vietnam area, okay, my dear friend Barkley. Barkley published this article there. They want to look at, they in this article, just to let you know, this article is anti-tissue graft, okay? But naturally, it's published by all surgeons, naturally, okay? You don't need tissue graft. Why not? Because in this study, what they did is this. They look at teeth that, they try to look at CBCT scan to see, does the thickness of the bone, of the labial bone around the implant have any correlation to the thickness of the soft tissue without tissue graft? All right? So what they did is very simple. They look at CBCT scan, look at patients that need 2 implants, right? They measure the buccal bone thickness, then they measure the facial soft tissue thickness and the crestal soft tissue thickness to see whether there's any correlation. Well, the answer is very simple. Based on this study, called anti-tissue graft, buccal bone thickness has a high association with soft tissue thickness. That means what Mark is telling you is the more you graft the bone, the thicker you make it, the soft tissue will naturally become like that. I don't know. I mean, I've been doing surgery so many years. Did you see that? I don't see that. I mean, there's no automation. I don't see a relationship. But what I'm more seeing is study like this. That's probably in 2012, okay? What this group of researchers did is it's very simple. All the implants in this patient, all the patients in this study need an anterior implant. And they split them into two groups, got it? One group is after they do immediate implant placement, they put a piece of sashimi on the facial aspect of the bone, got it? The other group, simple, no sashimi, okay? And what did they look for? They wanted to see how thick is the tissue, and by doing tissue graft, will that thicken up the tissue? Very simple, right? So what did they look at? Let's look at it. No tissue graft, you see that? Two groups. And the baseline measurement, that means after they extract the tube, they do a measurement. That's the baseline. It's from 1 millimeters. Remember? 1 millimeters? Got it. What happens is, 1 year later, what do you think will happen? When they remove the abutment of the crown and they measure the tissue thickness 1 year later, with or without tissue graft, what do you expect to see, ladies and gentlemen? Well, one of the two numbers you're about to see, you say, I expect that. You don't need to show me, I know it. But let me tell you, the second number that you're about to see, it will surprise you. So let's take a look at the two numbers. The number on your right, 2.6, you expected. Why? Because you do a tissue graft, 1 year later you measure, of course it thickens up the tissue somewhat. But what happens to the other group, in which no tissue graft yet? Like a miracle, the soft tissue still thickens somewhat a little bit. Why? Okay? In fact, this is what they find out every time. Why is that? When we do implants in the aesthetic zone, if the surgeon places implant paratally and the resulting is under contour, the facial aspect of the prosthesis, guess what? By leaving a gap between the healing gingiva to the implant prosthesis, a lot of times the soft tissue have a tendency to proliferate, ladies and gentlemen. That means it will automatically become slightly thicker. However, we also know that by doing that sashimi graft, it can thicken the tissue a little bit more. So what's the big deal? What's the big deal? Why is it even important? And if you look at these two numbers, I want you to remember these two numbers. In fact, when I compare to the literature that has been published over the years, this is what I found. You look at a group without tissue graft, but they emphasize that under contour. My dear friend Kalapoglu, Simback is from the Irina Saylor. I just was on the phone with Irina Saylor from Switzerland 2 days ago. So they're a very strong research team from Switzerland. They all show that without tissue graft, by under contour prosthesis, you can essentially thicken the soft tissue. However, you know, my dear friend Yuli and Ronnie, you know, they published this article with the tissue graft. What did they find out? Well, basically, you know, it can essentially thicken up the tissue. So again, I just want you to remember these two numbers. 1.4 and 2.6. What's the big deal? Why is it needed? To summarize it, I'm going to use this article by Ronnie. Okay? Ronnie, my friend Ronnie and Irina and Professor Hammerley from UMass basically published this very interesting pig jaw study. Okay? Very simple. What they did is this. They want to look at how thick of the overlying gingiva it takes to mask the underlying restorative material. Got it? And they compare 4 groups of restorative material, so they make 4 discs. The first disc made of zirconia. The second disc made of zirconia on top, put some porcelain on top of it. The third group is made of titanium, and then the last one is titanium on top, put some ceramics. And they put those discs underneath a pig jaw, and then doing tissue graft to create 3 different levels of gingival thickness. 1.5, 2, and 3 millimeters over it. And then to check how thick tissue it takes to mask the underlying restorative material, they use this machine called spectrophotometer. And the unit is called delta E, very simple, okay? But this is the result. Let's take a quick look, all right? So you can see the 4 groups of restorative material, titanium and zirconia group, you see that, right? And you see the 3 different layers of tissue thickness over this 4 different type of material. Blue is 1.5 millimeter thick, gray is 2.0, and orange is 3 millimeter thick, got it? So then they use the machine and check. Now there's one thing missing on this little graph here. What is it? That is, what is the delta E for a young human being? Young. I emphasize young. Why? You guys are all dentists, I believe this is a dental conference, right? You guys are dentists, okay? As a dentist, how many of you have ever experienced that, especially as your age approaching around mid-40s, okay? Mid-40s. And then when you take your wife out to a really romantic dinner, the room is kind of dark, and the waiter serves you the menu. You look at that menu, you look at it again, you look again, you cannot see very well. You say, I need my loops. How many of you have done surgery? When you do surgery, you have an assistant, right? I want you to think, when you do surgery, what is the most common words you tell your assistant to do? What? Suction? What else? Retraction? What else? Lights. That's what I do every day. Lights, retraction, suction. After 20-something years, my assistant gets so tired of me. One day when I say, suction, lights, or whatever, she suddenly stopped and said, Dr. Kan, it's not the light, it's your eyes. I love my loops. It's not the loops, I need that light. I need to have a loops that have 4 lights now, 4 headlights, or 6 headlights, that's even better, So, but point is this, what are the young human beings, their eyes are good. What is the delta E? What we learn is, in sciences, delta E for young human being is around 3.7, got it? So what that means is anything above that line, ladies and gentlemen, as a young human being, you can see a color differences, discoloration. So what can you learn? If the tissue thickness is 3 millimeters, you cannot see any color change. But if it's 2, most of the time, you don't see the zirconia group, but you see something show up on the titanium group. Okay? So if you look at it carefully, this is what you notice. The tissue needs to be above 2 millimeters thick in order to mask underlying resorptive material. And in fact, we just published a paper between the American Academy of Periodontology and the Academy of Osseointegration is on the consensus of periodontitis. And one of the risk markers, when we look at the odds ratio and so on, one of the risk markers for periodontitis is the soft tissue thickness. Anything less than 2 millimeters or 1.1 millimeter, you increase the risk of having bone loss around the implant, which is very interesting, okay? So the point is this, we want to try to gain 2 millimeters. In fact, you look at this patient of mine, I just delivered the patient's crown, the left central incisor, that is. I actually used this patient for life surgery on one of the perio meetings in the United States, for life surgery on stadium, okay? So I did a few big life surgery in my career. The biggest one was a few years ago, I did a live podium surgery for the American Academy of Periodontology, okay? On anterior. So this is one of those cases that I did a live surgery. And I want to show you the long-term results. I delivered the crown. I think you like the results, right? The patient's husband doesn't like the results. I said, what's wrong? She said, my wife's gum looks dark. I said, really? So let me show you another picture, just taking within 30 seconds of the picture on your left. Got it? So same day, one is with a smile line, one is without a smile line. If you look at these 2 pictures, which photo shows the gum looks darker? That's right, one picture on the right. Let me teach you this trick here. Okay, it's almost like the same patient taking the same moment with the lip. It's like walking out there with the umbrella. The sunlight is going to hit the umbrella first before you hit your face and create a shadow. So if you want your gums to look good when you do your cases and show off, forget the lips. Remove the lips so the light will hit directly to it. Because once you have the lip, anytime there's any darkness, it will exaggerate it, you understand? It will exaggerate, make it expressive. So in fact, okay, I mean, this is the patient that when I did the live surgery, I just want to show you something interesting, okay? This is the patient in 2008, when the tooth was failing, and right before the surgery, moved out and moved the lip, you see that? And 2010, remember when the husband's complaining, moved out and moved the lip. 2024, I just saw the patient last year for a recall, okay? With the lip. You can see the gingiva, you see, moved out and moved the lip. It stays consistent. Now, let's quickly look at, oh, by the way, so my point is this, all right? This patient has zirconia crown, zirconia abutment, and yet there's still some discoloration being expressed. So the point is, the goal for you as a surgeon when we do implant surgery for the sake of aesthetics is to try to achieve 2 millimeters facially, right? In fact, I look at her 16 years later. Sometimes, you know what, thanks for inviting me to speak, but the longer I practice, the more humble I get, and time is my best teacher. Look at that. I can spend all the time trying to make sure the color matches, the ginger is perfect,